This video covers some of the important points in balloon pump retrieval. I will cover some of the basics, talk about patient preparation, cover some transport considerations and troubleshooting the pump. And so regarding the basics, the pump rapidly shuttles the same helium in and out of the balloon chamber, which is located just distal to the left subclavian artery. The balloon inflates during diastole using the dicrotic notch or AV valve closure to time inflation, and it deflates during systole. And so what does that achieve? Well, inflation during diastole improves aortic pressure and also improves flow back down the coronaries, whilst deflation during systole reduces afterload and also myocardial oxygen consumption. Listed are some common indications for insertion of balloon pumps. We find that most of our patients are those with residual high-grade stenoses and therefore as a bridge to CAGs. Some contraindications are listed here, and these are fairly intuitive. Looking at our figures, we see that about 1/3 of the patients are intubated, about 2/3 are on inotropes, 2/3 are done by Rhode and the rest by Helo, and the majority done during daytime. Remember that there are two types of balloon pump used in New South Wales. We carry an Arrow balloon pump, and the other one you will come across is Datascope, which has now been bought over by Mackay. Listed is the rest of the information that we recommend you take during the initial telephone call. Balloon pump jobs are invariably long missions and as such should be planned thoroughly. When there is a road component, we recommend you land at Bankstown and transfer the last part by road in 794 or 795. In terms of who should go, if it's an intubated patient, we recommend 2 doctors, consultant and registrar, consultant to manage the balloon pump and registrar to look after the patient. In terms of patient packaging, it is recommended to use a tegaderm to stick down the balloon pump leads to the patient. This helps identify them as the balloon pump leads, but also helps reduce chance of dislodgement during transport. The catheter itself should be secured at multiple levels to the patient, and patients can be transported sitting up to a maximum of 30 degrees. As always, it is the doctor's role who's managing the balloon pump to be vigilant and manage not only the pump but also the catheter and the leads. Although the literature will say that there's up to 3 hours of battery life, in real terms this may be as little as 45 minutes, so please keep the balloon pump plugged in on AC power at all times. Regarding the helium supply, a 500 psi helium cylinder will last several weeks on 1:1. We recommend changing the cylinder if the psi drops below 200. A spare full cylinder is kept in the blue bag attached to the pump. With regard to transferring between different types of pump, clearly going from Arrow to Arrow does not pose a problem. If moving from a Datascope pump onto our Arrow machine, a number of the blue connectors shown in the photograph are kept in the blue bag attached to the side of the pump. And it's clear from the photograph that the Datascope connector easily fits into the back of this. This arrangement will allow easy transfer onto the balloon pump at the receiving facility, whether it is Arrow or Datascope. The only time that the driveline tubing may need to be cut is that if the patient was initially on an Arrow pump and we transported the patient on an Arrow pump but now is being transferred over to a Datascope or Mackay pump at the receiving facility, in which case the Arrow connector may need to be cut away and a Datascope connection inserted. The 3 steps in order to establish the patient on the balloon pump is firstly to turn the pump on, then establish all patient connections starting with ECG, then arterial pressure connection, and lastly swapping over the balloon driveline itself, and finally press the green button on the home screen in order to start pumping. When the pump is turned on, the default parameters are that it will be in autopilot mode on a 1:1 assist ratio with a full balloon volume, meaning 40 cc, and all alarms on. It is recommended that you don't make any changes to these default settings unless you want to move to a 1:2 assist ratio in order to assess timing or assess the assisted and unassisted pressures. When moving the patient, remember to use the red tethering strap at all times. It's also recommended to use bag ties to connect the driveline and the leads together, which reduces risk of snag and therefore disconnection. It is advised to walk with the pump at the back and as always it is the doctor's role to be vigilant, watching the connections at all times. During the transport of a patient on a balloon pump, there are a number of important topics that are worth a mention. It is important that the balloon pump is secured properly at all times. Vibration can cause loosening of connections and ECG artifacts, so it's important to have arterial pressure available as a backup. And noise can cause alarms not to be heard, so it is recommended to keep the balloon pump console on your lap in order to be able to visualize alarms on the screen when they go off. Pressure changes with changes in altitude will cause the balloon pump to alarm approximately every 500 feet. This will be a high pressure alarm on ascent or a helium loss alarm on descent. Requesting slow ascent or descent from the pilot will mitigate but not entirely remove this problem. When this occurs, the pump will alarm, stop, turn itself off, vent the helium and automatically readjust to the change in barometric pressure. In order to reinstate pumping, press the blue reset key, which will cancel the alarm, and then the green on key on the screen, and balloon pumping will resume. A few troubleshooting problems are worth a mention. If blood appears in the drive line, the pump should be stopped, the tubing should be clamped, and alternative support such as inotropes should be used. If the balloon is partially pulled out, please do not attempt to reposition it, but monitor the distal pulses and keep an eye on the urine output. The balloon pump volume itself may be manually dialed down in order to maintain a fairly normal looking balloon pump waveform. Should the patient develop an arrhythmia, as long as the pump remains in autopilot mode, it will continue to scan for the best trigger and optimize inflation and deflation timing according to that. If the patient arrests, initiate ACLS as appropriate, but do not turn the pump off. CPR will generate an AP signal and the balloon pump will continue to pump and augment your CPR. Lastly, should the pump need to be turned off for whatever reason, as the balloon itself is thrombogenic, it is recommended to inflate and deflate the balloon manually once every 10 minutes with the 60ml syringe that is supplied within the blue bag. Remember that there are checklists available within the blue bag attached to the side of the pump that should be revised pre-mission. It is highly recommended you stay familiar with the pump by turning it on and having it play every now and then when on base. I'm happy to be collared any time also to run through a practical session. If anyone wants any more information, there is a 2-day workshop run twice a year by Mayo Healthcare. And thanks for listening.